Thank you for inviting me to do this talk. I've never had a talk that had a curse word in it before in the title, so that's fun. I don't have any financial disclosures, but shit's going down. So when I was trying to wrap my head around how to give this talk, I was thinking about how surgeons are frequently compared to pilots, or how our training systems, our checklists, and all of that are pulled actually frequently from aviation. And I listened to a podcast actually from Behind the Knife about taking training of Blue Angel pilots and incorporating some of that information into training surgeons. And we're frequently also compared to soldiers in battle on combat, especially when we're dealing with trauma or crisis situations. But I had never really thought about comparing us to truck drivers until I was listening to the radio on my way into Round on a Saturday morning, and this radio episode came up, and it's about Canadian truckers, and there's really a lack of good drivers there, and so they were interviewing this trainer of truck drivers.
A lot of people are surprised I can actually do this as a trainer because I have a control issue when I'm driving, right? I want to be the one driving. I know what I have to do.
So how do you do that when you're a trainer?
Lots of breaks for cigarettes when they start. I learned, yeah. I have no controls here to help. I can shift pretty good. I always have the emergency brake, right? That's the final option.
So I don't know if that resonated with anybody else. But some other quotes from this are that really it's based in safety and the mentality of safety during training, breathing and using control of your stress responses, really being prepared for things and not getting lazy and using just the automatic cruise control, and then doing pre-trip inspection and being prepared for possible crises down the road. And all of these things are actually going to be themes as I continue to talk. So then I was thinking, what are we doing as surgical educators? We have to make these, they're not athletes, but like Dr. Jackson said, they're elite performers. And we have to teach them not only how to operate, but to have enough knowledge to diagnose and treat surgical patients, and to do this with really good non-technical skills, because a lack of non-technical skills is associated with medical error and surgical error. So what could possibly go wrong in all of this, right? We have to have difficult conversations. We can kill people, hopefully not a 300% mortality rate like Dr. Lister and his infamous amputation case. We have to deal with surgical error and the legal side of that. And then there's also moral injury and burnout. So how do we deal with these things? A few of these things are going to be familiar, which is helpful because I'm going to just present this framework, which is similar to what was presented before, and then I'm going to expand on it to help you have a better framework for how to teach residents when shit's going down. And if you think about the Swish model, I think of it as actually a continuum, and you can move from location or quadrant to quadrant during an operation or during an encounter, during a situation. And in appropriate times, you go back to show and tell or modeling, and in other times, you get to sit back and watch. And I think that's an important thing to remember when we're dealing with crises as well. So what we're trying to avoid is this, and I did read that the driver of this semi was actively on TikTok when this happened, so we also want to try to avoid social media and overuse of YouTube. But ultimately what we're trying to avoid are complications, but then also learn how to deal with them. When we're dealing with complications and crisis situations, whether it's intraoperative, whether it's postoperative, whether it's a personal problem or a difficult conversation, what that is a stress-inducing event. And stress contributes to your performance. If you're in the low to moderate or the moderate to optimum area of stress, it really can actually help you focus, activate the performer in you, and provide better outcomes and better productivity. But when you get into extreme stress, especially in an acute reaction, you can actually have loss of your focus, loss of your your non-technical skills, deterioration then of your cognitive ability to make decisions, and your technical skills as well. And when we get to chronic high levels of stress, that leads to burnout and moral injury. So one of the most important things we can do is to prepare ourselves and our trainees on how to control the stress response system. There's both the physiologic and then the cognitive side of it, and understanding that sympathetic nerve system, the high heart rate, the increasing respiratory rate, the steroids and stimulants that your kidneys and your adrenal glands are secreting, and being able to control those so that you can manage crisis and continue to teach is very important and something to practice. And also then being able to control the cognitive overload that comes with stress is important as well. And so this is where that practice and breathing comes in. So the technical framework I'm going to present expands on the original one, is going to include preparation, executing a mission, having a rescue plan, and really being prepared for a crisis. And then the after-action review and closing the cycle is that debrief. So preparing and practicing, there's a lot of ways we can do this. I'm going to go into a couple of these in detail, but simulation we know has helped to prepare people for crisis situations. A simulation situation versus a real life crisis situation are not the same because of the stress response that happens when you're not in simulation. It's a little bit dulled with simulation because you kind of know it's not real, but it still helps prepare you for that and to create kind of that motor memory and automatic response to help you control your stress and manage the situation. Preoperative planning and discussion is that it can be at the scrub sink or the night before a phone call. Set those goals, have a plan, and then that way, when something doesn't go right, you can take that and move into the swish model that works for you there. I'm going to go on war games. This was one I thought was very interesting. It's similar to oral board scenarios, but something that you can incorporate into your either daily or weekly rounds or education with residents. It's a space of psychological safety where they can make error and recover. And you're basically just providing them a situation, very simple questions, moving them forward, and then putting them into very difficult situations and making them figure out how to deal with it and recover, so that they've done that verbally before they have to do it physically with a patient. It's non-punitive, which is different than the oral boards, but a very formative education experience. And then it also helps them get ready for their boards as well. And then mental skills development, there are some published curriculum for these and some pretty good data showing how it can help manage stress and counter the visceral response. So breathing exercises can actually help reduce your heart rate. Obviously, it reduces your respiratory rate. It can drop your blood pressure, and it can help you take control of that physiologic stress response. Cognitive restructuring is learning to take a negative thought and try to reframe it into a more positive thought to help you with that relaxation and focus. And the refocusing strategies will help you look away from that big stressful picture, kind of break it up into pieces, and then focus on the piece that you can address right now and move on. And there are some good studies on these, and actually already curriculum that you can use to include into your training. So now what? Oh shit, now we're in the midst of it. And this video, Dr. Prabhu presented at SAGES a couple years ago, and it just, to me, was a good example of this interoperative crisis. You could see there's some foreshadowing because it said aorta right there. So right now, Dr. Prabhu said, oh shit, and then she said, switch. So she pulled that emergency brake and switched locations with her resident so that she could take control of this situation. Got control and then asked what's next. And I think one of the most important things I want to say about these crisis situations, especially interoperative, is that although we are trainers, we are surgeons first, and the patient's safety is what should come first and be prioritized. So we're going to focus on that first. Then we're going to manage our own stress. There's the old adage of check your own pulse. This is what you're going to do. You're going to get control of your own, and then you're going to help your trainee manage theirs too. And a way you can do that is through effective communication. You become the leader of that room again. You tell the nurses what you need. You figure out what you're going to do for the patient, and you do it in an authoritative, not mean, but you take control and you have communicate effectively so that you can solve the crisis. And then you use modeling while you're doing that, which is actually the show and tell of training, where you're going through actions but verbalizing not only what you're doing but your rationale behind it. And there's a lot of educational value in modeling and is probably the best way to continue teaching through an interoperative crisis. So then after you've taken care of it and everybody can settle down, you really want to do a debrief or have an after-action review. This allows you to review the events, compare how you reacted and what you did to what would be standard or what the expectations in that situation would be, and then to use self-reflection. Ask the resident what went wrong, why did it happen, what strengths did we see of how we responded, and what were the areas for improvement, and then be vulnerable and do that yourself and verbalize it for them as well so that they can see that. And then finally complete the cycle and make sure you incorporate the lessons that you learned into the resident or the trainee's continued training, maybe put it into M&M and some of your didactics, follow up with the trainee that's in that situation with you and provide the support, whether it be psychological or social as needed. So I'm going to end with my takeaway points, which really mentally rehearsing and practicing before a crisis will help you manage that crisis and your own stress. Verbalizing your thoughts during a crisis while you're responding in action can be very educational. And it's very important to standardize that debrief or the after-action review and to incorporate those lessons so that they can be moved forward. Thank you.